Good afternoon, everybody. I hope I'm audible. My name is Anurag Shrivastava. I'm the professor of psychiatry here at MIMS. We'll be beginning our journey of 15 or so lectures now, and we hope to be able to cover most of the major disorders in psychiatry. Now, psychiatry is something which fascinates a lot of people, and mm, stigmatizes a lot of people as well. So there are some people who are really curious to know about mental illnesses and people who are suffering from psychological disorders, and how we can psychiatry also help people who are not really suffering from any disorder to live better lives. And on the other hand, there is a fair amount of stigma about mental illness. So today what I thought I will do is that I will give you a brief idea about how to approach history taking in psychiatry and give a glimpse of how we are going to do a mental status examination, even though the mental status examination will be taken up in more detail in a subsequent class. So history taking is especially important in psychiatry because we don't have any diagnostic tools to help us to diagnose any disorder. So uh, we cannot do a CT scan or an MRI scan of the brain and come to a diagnosis in psychiatry. That is because most of the all the disorders that we are going to talk about don't really have any definitive diagnostic features on any investigation. So diagnosis is entirely dependent on a good history taking. And while history taking is important everywhere, I think that because it's the cornerstone of diagnosis in psychiatry, the best place to learn history taking is actually in psychiatry. So first of all, let me try to explain why this thing is so important. So if you think about it yourselves, how does a layman think about a person with a psychiatric illness or a mental disorder? Most of us will think that people with mental illness or psychiatric disorders will be behaving oddly. They will be um, talking or walking or dressing in a way which sets them apart, and we can see people with mental illness and diagnose them that okay, this guy has got a problem. Unfortunately, behavior is a very poor way of diagnosing mental illness. I'll give you an example. So for example, in in our culture, certain behaviors will be seen as very abnormal, which are seen as normal in other cultures. So for example, if one day my daughter comes home with half her head dyed green and another half dyed saffron, it might throw me into a bit of a tizzy. But on the other hand, many other people would say that she's just expressing herself and she's being patriotic probably, and she's just saying, making a statement. On the other hand, if we tell, so we meet a lot of our counterparts, for example, American psychiatrists in conferences, and they have generally a lot of respect for our clinical skills and all, because we see a lot of people, far more than they do, because our population is so huge and the number of psychiatrists is so small. But when if you get into a conversation with them and they will general things, and they ask you, so how did you meet your wife, and you say that, well, it doesn't work like that here. I didn't meet her. There was a marriage bureau, and I went through some 50,000 photographs, and finally I liked this photograph, and then we approached the marriage bureau, and then she also liked my photograph. So then the parents set up the meeting, and one of the things which was done before the meeting is to match horoscopes. So by now the American is looking shocked and looking a little distressed. He really? And you say, yeah. And they say, so what is a horoscope? So you explain to them that basically we have to decide that the position of stars in the sky at the time of my birth matched the position of stars in the sky at the time of her birth, and if these things match up, then we can go ahead. By this time, most of them are ready to faint. For them, it is incomprehensible how we can leave such an important decision as marriage to the aligning of stars in the sky and decide in a few brief meetings whether this is the person I'm going to live with. And they are also a little appalled by how much the families are involved in this, and then they are taken aback by our lavish weddings. So you see, that behavior, which is absolutely normal for us, in fact, we would probably not have it any other way, appears very, very abnormal to people who are not familiar with that culture. So the point that I'm trying to make here is that trying to make a psychiatric diagnosis based on behavior is going to lead us astray a lot of times. Psychiatric diagnosis is based on four pillars: abnormalities in one or more of these areas, and these are mood, thought, perception, and cognition. Mood, thought, perception, and cognition. We do take into account appearance and behavior, absolutely. You will see that in the mental status examination, the first point which is mentioned is appearance and behavior, but it will be a rare diagnosis which will be made on appearance and behavior. In fact, you cannot make a diagnosis merely on appearance and behavior. It will be noted and it will be sort of additional evidence that, okay, there's probably something wrong here, but you cannot diagnose anything based on appearance and behavior. An example of a disturbance of mood, for example, is depression. Depression, major depressive disorder, is an example of a disorder of mood. Schizophrenia is an example of disorder of thought. Perceptual disorders by themselves don't make a diagnosis, but hallucinations are, for example, an example of perceptual disturbance. Delirium has a lot of perceptual disturbance. And dementia is an example of disorder of cognition. So you see, whenever you need to make a psychiatric diagnosis, you have to be able to point out the problems or the disorder or the dysfunction in one or more of these four areas, which is mood, thought, perception, and cognition. So our mental status examination, which is the formal report we'll write after examining a patient, will have these 5 points: appearance and behavior, mood, thought, perception, and cognition. These are the 5 headings in which we will finally write our report, that this is how I have examined the patient and this is what I have found, right? We'll see that in greater detail. But the important thing in history taking is that our focus is on finding out abnormalities in one or more of these areas. And that is where psychiatric history taking is a little bit different from the history taking that you have been taught in other disciplines. Because in nearly all the other disciplines, with probably some exception if you're taking a neurological history, the higher functions of the mind are not much examined. Maximum you will examine the orientation and the consciousness and then leave it at that. If the patient is confused, you want to see whether he's oriented, whether he's conscious, but leave it at that. But psychiatric examination actually begins where all the other examinations have been left off. So our entire examination is on the higher function of the mind, and so our history has to be tuned has to be adjusted or has to have a speciality function in it which pays attention to the higher functions of the mind. So, for example, in orthopedics, you're unlikely to ask a person how their mood is. Well, most of the people will not be in a good mood after fractures anyway. But that is not the focus of attention there. But that is very much a focus of our attention, and that informs our history taking. So that is the one great fundamental difference in the history taking that you see in psychiatry as compared to other branches, that the focus is on eliciting, getting the patient to talk about and detailing abnormalities in the higher function, focusing on mood, thought, perception, cognition. Right? We take into account all complaints, but these things are not focused on in other histories, and this is what we pay a lot of attention to here in psychiatry. So if you look at the format of the history taking, that is not so much different. So we take the demographic data just as you take demographic data in other things, which is the name, age, gender, language spoken, address, where do they live, marital status, education, occupation, income of the family, so that you can have a rough idea about the socioeconomic status. So those are common in general. This is what you would take in any department. After that, we go to the presenting complaint or the chief complaint. And here, see, what may happen is that, so first of all, people may come with multiple complaints. It is our job to try to find out which is the chief complaint in all of those. Chief complaint basically is the most pressing problem that is bringing the person to the hospital today. And it is our job to try to find among all of the complaints that the person has come with, which is the pressing complaint here, which has brought him to the or her to the hospital today. Sometimes it becomes difficult to get the person to identify one single complaint, and they might insist that, oh, I've got sleep disturbance and I'm very anxious. So both of them are very important for me. And you may not be able to get them to say that, no, it is the sleep disturbance or the anxiety which has driven me here. One of the things which I generally try to ask people is that if you could solve one problem of all the problems that you have, if you could solve one problem, which problem would you solve? And that sometimes helps us to understand that, okay, this is the thing which is bothering them the most and which has brought them here today. Also, so try to bring it down to the most important complaints. Sometimes you may go to 2, but don't write a list of 7 chief complaints. Then the essence of the word chief is lost. So if you say that the patient has presented with chief complaints of nausea, vomiting, diarrhea, headache, insomnia, restlessness, anxiety, irritability, and body ache, this doesn't make sense. Because there are too many of these, all of them cannot have the same severity, would not have developed at the same time, and all of them will not be the primary reason why the person has come here. So try to talk to the patient to get a feel of which is the most important thing which has brought them here today. The second thing which is important is to understand that the chief complaint need not be the most serious thing that the person is suffering from. For example, there can be a patient of bipolar disorder, which is probably the second most severe mental illness there, but he might say that I have a headache. I've come, the headache is killing me, and I've come because of a headache. So the chief complaint may be a headache, but actually when you look at the history, you may find that that person is talking excessively, is not sleeping at night, is spending tons and tons of money, is very abusive with the family members, is picking fights, is has gone on a shopping spree, has not kept up his business commitments, is talking non-stop, but the person complains only of headache. So sometimes the chief complaint or the presenting complaint need not be the most serious thing the person is actually suffering from. We discover that later on, that he is complaining of a headache, but actually he's got a ton of problems, a plethora of problems behind him. So don't be taken in by the fact that he is saying something trivial or something not so distressing. And also don't feel that you are obliged to report the most serious medical complaint as the presenting complaint. Basically, it is the one which causes the patient the distress the most which should be presented here. One other thing that we take note of in psychiatry is the informant. So the patient himself will give the history or herself will give the history, but there are certain psychiatric disorders, and most of the times the history is pretty reliable and accurate, and you can count on it. But there are some conditions, especially the psychotic conditions or the bipolar disorder just mentioned, in which the patient may not have any insight, may not realize that these things are illnesses, may believe them to be true and may not report them. Or the patient might be hostile or vigilant or guarded or suspicious, and so they may not reveal all of the history. We need a good attitude and good skill to be able to get history in these difficult conditions. But we are obliged to also talk to in fact, we always talk to the family members who are present to get their perspective on it. So the informant in these histories will be the patient and some relatives, family members or friends who have accompanied him or her. In these cases, it is also important to understand whether the information which you are getting is reliable. Now, how do you know whether the information you are getting is reliable? Basically, you look for two things. You look for adequacy and you look for consistency. Adequacy means, are you getting enough answers to the questions you are asking? Or are you getting a lot of vague answers, or I don't know, or I can't remember? That means that you are getting a lot of answers which don't really answer your questions, so the information is inadequate. If the information is inadequate, it is considered to be unreliable. Similarly, if the answer is not consistent, so for example, the person at one point of time says that I don't have any problem, and another time says that I have not been able to sleep for a week, later on says that I've been sleeping fine. The inconsistencies in the history can make it unreliable too. So reliability of the history, reliability has to be judged for the patient as well as for the relatives or the attenders who have come with him or her, and that is based on adequacy and consistency. Then we come to the history of present illness. History of present illness is basically a chronological description of all the problems that the patient has faced. Now remember, these people they have not read Hutchison Hunter, or they have not read any history taking textbook or guidebook, so they do not present the history to you neatly in chronological order. That is the rule. Patients will talk about the things which affect them the most, which bother them the most, and it need not be the one which started first. So the art of history taking, which also we will take in a little more detail, allows you to be able to think calmly, listen to the patient with patience, and listen to the information which may be presented in a haphazard way chronologically. They may talk about something which happened 10 days ago, then they may say that I had fever yesterday, and they may remember that, 2 years back also I had the same thing. So it's all jumbled up. The trick is to listen patiently, keep an eye on all of those things, and ask the necessary questions to get the details. But when you are going to report the history, when you are going to write the history, then report it chronologically. That means you start with the thing which was which started first, the earliest, and then you go down the course of time to see how that complaint or that symptom has progressed. Some symptoms become all right, new ones start up. So pick up all of those areas of concern, starting from the one which started the earliest and bringing it down to how it is presently, and then picking up the next one and bringing down, so that all of those complaints, when you report them, are arranged chronologically. Sometimes, you cannot just distinguish each and every symptom like that and describe each in individual capacity. You may have to describe two or three different symptoms because they are running simultaneously, but keep them chronologically. So, for example, you may say the patient first noticed that he was not feeling well about a year ago. He started noticing that he was getting headaches, which are more on the right hand side, and gradually progressed to involve both sides of the head. And then he was having headaches for once a week, and now they have progressed to daily. They used to last 3 or 4 hours in the beginning. For the past 1 month, they have been lasting the whole day. In the last 1 month, the headaches have been associated with some nausea, but there's no vomiting. So you have described this, but what has happened is that 6 months back he started to have insomnia as well. So while you are describing this, you can either take the headache down to how it is today and then go to the insomnia. And sometimes what may happen is that it is very difficult to distinguish between all of these things together. So while you are describing the headache, so it had started with once a week, and then you can say that 6 months back he started having insomnia. So you have brought in the insomnia also into the picture, and then you have gone back to describing how the headache has increased in the last 1 month, and you have described the increased frequency and duration and severity. And then you also point out that in the last 1 month his sleep disturbance has also worsened, and along with that he has started to feel very anxious and restless, and he is unable to concentrate on his work. So all of these things have happened in the last 1 month. So what is happening is that you are arranging all the complaints that the person has had, and you are trying to put them in chronological order, so that when you read the history you get a picture of how things have been unfolding. Yeah. Then comes the special focus that we were talking about. So while most of the patients who will come to you will generally talk about physical complaints, they will talk about headaches and body aches and fevers and whatever other physical things they may have, but they may not talk about psychological things, because the perception is there in many people that we cannot talk psychological things with doctors. So patients are likely to tell you about their chest pain, but they're not likely to tell you that my mood hasn't been that great. I have not been feeling that well the last few months, and in the last 1 month, I just don't feel like getting up. I don't feel like doing anything. I have lost interest in things. They may not tell you all of that. So what you have to do is, keeping in mind the 4 pillars which we have, which is mood, thought, perception, cognition, you must ask questions which are broad questions in the beginning about each of these things. So how have you been feeling? Generally they'll say, what do you mean? And you say that, how has your mood been? And then that can get something started. You can ask about their sleep, appetite, you can ask about their interest. So basically what we do is that when we are looking at the mood part of the history, we keep in mind the disturbances that people experience when they are going through a depression or a mania, and we tailor our questions to pick up those points. So for example, in depression, there are 9 symptoms of depression, which you will learn later on in this series. So I would tailor my questions to ask about sleep, about appetite, about memory and concentration, about energy levels, about fatigue, about restlessness, about guilt, about lack of interest in daily activities, about the mood, any suicidal ideation. So when I ask these questions, I am basically going through the checklist of depression and making sure that none of these is present, or whatever is present, I want to document that. Similarly, I may have to direct their attention to thought and perception. And so, for example, people who are suffering from schizophrenia may hear voices which nobody else can hear, and they may not tell me. because they might tell me some physical symptoms, but they may not tell me that I can hear a voice which nobody else can hear. They are worried about it, or they are paranoid about it, or they feel embarrassed about it. Not embarrassed really, but they don't think that this is something which I can talk about. But if you ask them that, do you ever hear any voices when you are sitting all by yourself? A lot of people would say that, yeah, you know, people suffering from schizophrenia, I mean, would say that, yeah, I can hear a voice talking to me. And then the more questions you ask, the more comfortable they get, and they can talk to you that is it a male voice or a female voice, and they might say that it's a male voice and it's actually my neighbor's voice and he is threatening to kill me. And that is the reason why I have stopped going to work, because if I get out of the house, I know that he's going to kill me, because that I can hear him talking and he's threatening me, and he's talking to his friend also, saying that as soon as this guy gets out of the house, we are going to kill him. So you see, there can be a deep psychological distress which is hidden, which is affecting the person's life. He has stopped going outside the house, he's living in terror, he has given up his job, it has had a profound effect on his life. But if we have not asked, they will not tell. And we might just say that, oh, he's lazy, he doesn't want to work, maybe he's got some stress at work, he just wants to be at home. But actually what is happening is that he is hearing his neighbor talking to his friend that we are going to kill this guy, and he's so afraid and he's so worried that he doesn't want to take that chance, and he doesn't step out of his home. So you see, in the history, if you don't ask questions about mood and thought and perception, many people are not going to talk about it. So a lot of people who are actually forgetful may not want to talk about it. So unless you ask them that, have you been forgetting things? And then they might say that, yeah, I have been forgetting things. I have difficulty remembering people. I forget telephone numbers. The other day, I'm very embarrassed to tell you, Doc, that I was coming back from my walk, and this is a park I go to every day. I've been going there for the past 20 years. But I found myself in a different locality, and I realized that I had lost my way. But they may not say all of these things until you ask them. That guy must just tell you that I've got pain in my knees and I'm having difficulty in walking, and that's it. But when you asked further, when you specifically asked about his memory, he said that, yeah, I've been having trouble for remembering things, and the other day I got lost on a well-remembered route. So you see, if you have to pick up psychological symptoms, you have to look beyond the physical, because people suffering from psychological disorders almost invariably will come and tell you physical symptoms. They'll almost invariably tell you physical symptoms. Very few people, unless they have seen a psychiatrist before or they have had treatment, very few people are going to walk into your office and say that I'm feeling depressed. It never happens. They'll tell you about their back aches and the neck aches and the giddiness and the difficulty they have going to work and all. They will say those things, but they'll not tell you about the mood. So if you don't ask, you are not going to get it, right? After the history of present illness, we move on to past history. Now there's a great deal of confusion between what is past history and what is present history. So let me set that right the way we do it in psychiatry. Past history implies all those illnesses which have been there in the patient's life, but they are distinguished from the history of present illness by a period of wellness. A period of 2, 3, 4 months, that can be variable depending on which author you are following, but somewhere between 2 and 6 months, the person should have had a complete recovery from that illness. Physically, emotionally, psychologically, functionally, socially, in every aspect he must have regained pre-morbid functioning status. Once such a thing like that happens, whatever has happened before that period of recovery is called past illness. Whatever is happening after that period of recovery is the history of present illness. So past history is not really dependent on how long we have had that illness. We can have an illness which is 20 years long, but it's a continuous illness with no period of recovery. There has been some recovery, but it's been partial. Patient has never been fully well. This kind of history is commonly seen in people with schizophrenia. Then the entire 20-year history is in the history of present illness. It is in the history of present illness. While a person may have only a 6-month history, but then it lasted 3 months and then he recovered and he has been well for the past 2 months and now something else has started in the last 1 month. So that period of recovery means that whatever has happened is in the past history, even though it was only 6 months ago. So past history is separated from present history by an interval of 2 to 6 months in which the person has been well in all senses of the word, has recovered fully to pre-morbid functioning, and it doesn't matter whether that recovery is because of medication, even continuing medication. That doesn't matter. Still, it will be seen as a recovery, and anything before that recovery will be seen as past illness. We record both the past psychiatric illness as well as past medical illness, surgical illness, obstetric illness, all depending on the situation. So, both psychological, psychiatric history in the past as well as medical history is collected. Then we come to the family history. In family history, it is imperative to draw a family tree. Generally, family trees should involve 3 generations. So, if there is a young person hasn't started a family of his own, then we go to parents, we go to grandparents, and we'll go a little laterally also and look at the uncles and the aunts, blood relatives especially. We want to have a look at 3 generations. Suppose there is an older person who has a family of their own, children and all that. So I might just go to their parents, them as the primary thing, and then the children. So again 3 generations, but it's not gone to the grandparents, it is rather gone to their own children. So depending on that age of the person, you can tailor this a little bit, but you should basically look at 3 generations. Now, what we look for in psychiatry, especially when we look at the family history, we look at each of the immediate first degree relatives, that is parents and siblings, and we want to describe 4 things about them, each of them. We want to say their age, their occupation, the relationship with the patient as described by the patient, and the nature of the person as described by the patient. So for example, a person may say that my father is 62 years old, he is a farmer, he is a very kind and sweet-tempered person, he is a very loving person, caring person, and I have a very good relationship with him and I consider him to be my best friend. So that is, it has captured the age, the occupation, the nature of the person as described by the patient, and the relationship which the patient shares with that person. Along with that, we are also interested to see if there is any history of any major mental disorder in the family. Somebody has been missing, wandered away, has been diagnosed with a psychiatric illness, has been hospitalized, if there is any history of substance abuse in the family, if there is any history of suicide in the family. All of these things we want to capture, because like all illnesses, psychiatric illnesses also have a pretty strong genetic base. So the more severe the illness, the more likely the genetic base is going to be strong. So for example, bipolar illness, which is one of the severest illnesses, has a very strong genetic component, as has schizophrenia, as have alcohol use disorders, as has also obsessive compulsive disorder or severe depressions. While on the other hand, adjustment disorders, somatization disorders, the milder generalized anxiety disorders are less likely to have that robust genetic connection. But it is important for us to document any history of mental illness in the family. We are going to go on for another 5 or 10 minutes, so don't worry. Right? I don't know if there is a chat box here where you can write in your comments. If you have, do write in, so I will be able to answer something if you want to. Otherwise, we'll take it you can sort of mail them in or text them in. We'll have to work that out, the feedback part of it. After the family history, we come to the personal history. Now, personal history is basically every important event in that person's life from his birth, in fact, antenatal period before the birth, right down to today. So that also has to be tailored. So you see, we have 45 minutes, 50 minutes to take a history. We cannot listen to a very detailed life history of everybody, but we want to capture the important points, the early milestones, the early childhood, middle childhood, late childhood, teenage, early adulthood, and then middle age and old age, depending on how old the patient is. We want to capture the major events in these ages. Also, it can be tailored. So if there is a person who has a master's in electrical engineer and has an MBA degree, I'm not that much interested that when did he start rolling over, when did he start walking, at what age he started talking. I may not, I want to know that grossly there was no problem and move on. On the other hand, a child 8 years old who has come with difficulties in school, I'm going to pay a lot more attention to the developmental history. So you can pick and choose a little bit depending on what the circumstance is, because to take a person's entire life history in a short period of time is, it's a difficult task. Generally we devote 15 to 20 minutes to personal history. To give you a timeline, the demographic data and the ice breaking questions are generally 5 minutes. Presenting complaint and history of present illness is 15 to 20 minutes. Sometimes the past history can be very long, but generally past history is 5 or 10 minutes, family history is 5 minutes, personal history is 15 to 20 minutes, and then we took 5 or 10 minutes to write our mental status examination and do a brief physical exam. So that is how the whole thing is distributed over an hour. So in the personal history, we want to capture the major things. So we are looking, it's basically in the early development milestones, early, middle, and late childhood, the teenage years, early, middle, and late. We want to look at adulthood, and then the streams which we are following here are, we want to look at the developmental milestones, we want to look at the education which leads on to vocation and what the person is doing now and socioeconomic status. We want to look also at the psychosexual development, the puberty, development of secondary sexual characters, courtship, marriage, and sexual life. And we want to look at the family of procreation, the marriage, children, and so on and so forth. We also look here briefly for any military history, any legal problems, and we also inquire into substance abuse. Any substance abuse problems have been there. Some people may be smoking or drinking. They may not mention it in their history, but we must ask about all substance of abuse in the personal history. We also try to get a feel of what kind of person the person was before this illness happened. So there are many points that we look at. For example, we look at what kind of attitude, work towards family, what kind of people they consider themselves to be, introvert or extroverted, whether they consider themselves to be people who like to lead or who want to follow, or they're quiet, are they social, are they less social, are they more interactive, do they like public people contact, or they're quiet, what is their general mood and temperament like, what are their hobbies and interests like, what are their religious political viewpoints. Again, all of these things, the details cannot be captured in this 15 or 20 minutes that we are giving to personal history, but we should try to capture the main points. Maybe 1 or 2 line questions that are you a religious person, any political affiliations, what are your hobbies and interests, generally how would you describe your mood to be, are you generally a cheerful person or do you tend to worry a lot, those kind of questions which give us a brief idea. That is called pre-morbid personality traits. So that winds up basically all that we need to look at in the psychiatric history. How to formulate this into a mental status examination will be in a subsequent class. I'm also going to take some time to talk about the art of history taking. Now that we have talked about the format of the history taking, I also want to spend a little bit of time to talk to you about the art. See, the art is very important because everybody doesn't give you the same information with the same approach. There will be some patients who are quite relaxed, they're friendly, they are trusting, and they will make a rapport with you quickly, and they will tell you whatever you ask them. There are some patients who are much more anxious, much more guarded, vigilant, suspicious, not very trusting, they're not very sure what they are in. Two, they may be reluctant to really reveal some information. They may be not able to open up with people. They might be embarrassed about things. They may be shy, and they may be sometimes be hostile. They may have been brought to you against their will or without their consent. Many families sometimes resort to tricking people to get them to see a doctor. Especially in psychiatry, this can be common, and so the person can be quite hostile. And to be able to conduct an adequate interview in these circumstances is dependent on your skill. It's dependent on your skill. One of the most important things that we can have is patience. We must have patience, and we must have adequate time. Because if you don't have adequate time, if there are 50 or 60 people sitting in your waiting room, you are in a constant pressure to get these things out quickly, and you do not have the time to build a rapport with the patient. You cannot listen to them, you can't let them ramble on about some things. Sometimes they like to talk about some things which are not very important, but it is important part of their rapport, and if you listen to that, then you can get them to talk about the things that you are interested in, which you want to know. So having enough time is very important. And then I think a great deal depends on your attitude. On your attitude. That do you come across as a warm, friendly, compassionate, interested person? Or do you come across as a cold, curt, in a hurry, or a judgmental, or irritated, or authoritarian figure? I've been talking to a gentleman whose wife was ill, and he approached me, and I told him that right now, like I'm not seeing patients physically, so she was quite ill, so she had to go to a hospital. So I recommended a hospital. They went there, and they were treated by a doctor there. But that guy keeps calling me and talking to me, and one of the things is that so the girl has obviously been correctly diagnosed and treated, and she's quite well now. But one of the things which is his major gripe is that the doctor who was treating was very busy. He did not have time to listen to my questions, he did not have time to address my concerns. He was very curt, and when I asked him that can we use something else, with this medication she is very drowsy, so he basically told him that you leave the medication to me, I know what I'm doing, and I will handle it. So that is doesn't land very well with people. That doesn't land very well with people. This guy says that I'm not going to take my wife back to him, even though she's been correctly diagnosed, successfully treated, and she is better. But now for the follow-up, he doesn't want to go there because he finds that the attitude of the doctor, he's too curt, and he does not allow any discussion. So you see, that is a very important part. The patient doesn't know how much Harrison you have read, or how much Davidson you have read, or how much medicine you know, or surgery. The first thing that they will make their impression about is how you come across to them. How you come across to them. Are you a gentle, kind-hearted, friendly person? Are you going to be rude and curt and judgmental? See, these things pay a lot of importance in how you will be perceived. Your knowledge will come later. Your skill will come later, obviously. But sometimes even that is not enough to establish rapport. They feel that, oh, there can be another doctor who will solve the problem, but who is nicer. So I think that a good rapport, establishing a good rapport, and that's a very important part of being a doctor. And I am going to spend an entire lecture on this about the art of history taking. All right. So let us stop for today. and we will see you next week, Friday, same time. If you have any questions, I'm going to set up a mechanism where you can mail in the questions. If you want, you can take my email straight away. It is I'll say that like Alpha, Singapore, Russia, India, Victory, Alpha, Singapore, then 2. ASRIVAS, then the numerical 2 at the rate of gmail.com. You can mail in your questions, and if the class representative will get in touch with us, we will make available all the material. For example, the history taking, the mental status examination, and the presentations on all the major disorders will make available so that the class can see them at their convenience. All right. So, till next week, stay safe, and I look forward to this lecture series with all of you. Bye bye.